guys. This is a question paper from Atal Bihari Vajpayee Medical University of Lucknow of MBBS first professional examination, which was held in January 2023. This was for MBBS students admitted in 2021. So this is a question paper of the main exam, and the subject is Anatomy Paper 2 Part 1. Question paper was of 3 hours, 100 marks. So the first question here is long answer question. This is a clinical question with 4 subparts. I suggest that you also have a look on the proportion of marks to each of these subparts so that you can write accordingly. That gives you an idea that how much you have to explain in that particular subpart. So total it was of 15 marks. A 50-year-old male patient presents with frequency, urgency, pain during micturition, and there is retention of urine. Now, what is the organ involved and what part of the organ is enlarged? See, it's of 2 marks, right? So you just have to write whatever is being asked. Don't bother about writing and describing much. That saves time. So the organ involved, what do you think? Because the symptoms they have mentioned is frequency, urgency, pain, and retention of urine. So you can very well guess the organ here, and the organ is prostate. The next is which part of the organ is enlarged. Now here let me tell you there are actually 3 different types of classifications describing the parts of the prostate. One is according to its development, where there are 3 zones. So the innermost zone surrounding to the prostatic urethra, encircling it, that's called the transition zone or the periurethral zone. Then posteriorly above the opening of the 2 ejaculatory ducts, that zone is called the central zone. And posteriorly the bigger part of the prostate lying below to the opening of the ejaculatory ducts, that's the peripheral zone. All this you need not have to write. Right now I'm telling you just to clear the concepts to make you understand. Remember, you just have to write the part of the organ. But right now I'm explaining it for your convenience. So this is how there are 3 zones developmentally. Remember, the peripheral zone is rich of glandular tissue that is made up of 70% glandular tissue. And remember, this portion, the peripheral zone, is common for carcinoma of the prostate, while the transition zone or the periurethral zone, which has only 5% of the glandular element, that's more prone for the benign hyperplasia of the prostate. Then the central zone, as I was telling, it has a development significance that this zone is derived from the Wolffian duct, that's the mesonephric duct. So this portion is of mesodermal origin. The rest of the prostate is endodermal in origin, which is being derived from the primitive urogenital sinus. And the central zone has only 20% of the glandular element, and this is less commonly involved in the disease process. So this is one classification of the developmental basis, and the other is the anatomical basis, where you divide it into lobes. So earlier there were like 5 lobes. You had is an anterior lobe, a posterior lobe, a median lobe, and the 2 lateral lobes. But now, according to the Gray's 42nd edition, it's been revised that there are only 3 lobes. You have is a median lobe and the 2 lateral lobes. That's the anatomical classification. The other one is a histological classification, where you divide it into 2 zones, the inner zone and an outer zone, which is a bigger zone. So the inner zone, which has small glands, the submucosal glands, which open directly into the prostatic urethra above to the level of this prostatic sinuses. So you can correlate this portion, the inner zone, which is comparable to the periurethral zone. Both are same. So this zone, the inner zone, histologically when seeing, this is common for benign hyperplasia of the prostate. While the outer, the bigger zone, which has large glands with large ducts, these glands open mainly into the prostatic sinuses. So this outer, bigger zone is common for prostatic carcinoma, right? So here you can write that the organ involved is prostate, and the part of the organ involved is the periurethral zone, the transition zone, the inner zone, or the median lobe. Then explain the causes of frequency, urgency, pain during micturition, and retention of urine. So now think about when this inner zone, the periurethral zone, so when it enlarges due to hypertrophy as well as hyperplasia, it grows both centripetally and centrifugally. Means it has an outward growth as well as it grows inside, compressing the prostatic urethra, decreasing the lumen there. So as the lumen will gradually keep narrowing, obviously the urine will not flow out easily, smoothly. So when it's not coming out completely, there will be a repeated frequency of the subject to go and urinate or micturate. So that increases the frequency. Urgency, because when the prostatic urethra is semi-occluded, the bladder will keep filling and stretching. So that will also cause pain and the person will feel it urgent to avoid it. And because in later stages there comes a stage where this prostate compresses the urethra from all the sides, means the prostate from opposite walls of the prostatic urethra touches each other, and that's called the kissing stage of the BPH. So that's nearly the stage of complete occlusion, or even before that, because of incomplete voiding. So what happens is there is retention of urine. And few features they have not added is that there is also dribbling of urine. When the person comes back from the urinals, he feels that he has not completely voided the bladder. So there is a feeling of incomplete voiding. So the last few drops keep dribbling. So that's why people in such age group with such problem, they also use male diapers. So this was a 5 marks. That's why this part you should explain in detail. Then describe the development of prostate and prostatic urethra. This is a 4 marks. So let me tell you that prostate is mesoendodermal in origin. Prostate is nearly a conical structure, a gland, which is wider above, the base is above and the apex is downwards towards the perineal membrane, with the dimension of about 4 centimeter above at its base. Transversely, vertically it's 3 centimeters, and anterior-posterior thickness is only 2 centimeters, and it weighs around 8 grams. Having this idea, now let me tell you that it actually develops by the evagination of the glands from the prostatic urethra. So that's why you should actually describe the development of prostatic urethra before. This you will have to explain with the help of diagrams. So you know that there was cloaca, right? Cloaca was forming the part of the urogenital as well as part of the GIT. The cloaca was divided by the urorectal septum into anterior primitive urogenital sinus, and the posterior portion was forming the lowermost portion of the rectum and upper portion of the anal canal up till the pectinate line. So cloaca was contributing to the lower end of the GIT, and now here we're talking is about the urogenital system. So this portion of the primitive urogenital system is divided into upper and lower portion. The upper portion is called the vesico-urethral canal, and the lower portion of the urogenital sinus forms the urethra in males. Now this vesico-urethral canal, the upper portion forms the urinary bladder, while the lower portion forms the prostatic urethra. So this much portion is endodermal. Now part of this urogenital system is also being derived from the mesonephric ducts, that's called Wolffian ducts. So you know that this mesonephric ducts descend down to join this vesico-urethral canal posteriorly at the lower portion where it was going to form the prostatic urethra. And from this lower portion of the mesonephric ducts, there were these ureteric buds arising, which was forming the ureters. Now this lower portion of the mesonephric duct gets absorbed or is taken up by the enlarging urinary bladder. So the proximal portion of the mesonephric duct and the ureteric buds is taken up to contribute to the formation of trigone. And when it's being absorbed, the two ureters, the ureteric orifices actually ascend upwards and separate out laterally. They move away and above, such that the trigone becomes a triangular area with a base above and an apex below. Now this pointed lower portion of the trigone, which is being derived by the absorption of the mesonephric duct, is also descending down to contribute to the posterior wall of the prostatic urethra, while the openings of the mesonephric ducts descend down to reach the level of the prostatic urethra, right? So all this is being formed by the mesoderm of the mesonephric ducts. These are the ureters, the trigone area of the bladder, the posterior portion of the prostatic urethra, and the lower and the mesonephric ducts are now contributing to form the ejaculatory ducts, which are opening in the lower limit of this contribution in the prostatic urethra posteriorly. So that's how prostatic urethra is being formed. Now, from the entire length of the prostatic urethra, their minute evaginations like simple tubular glands, they evaginate out from both the endodermal portion, which was being formed by the lower portion of the vesicourethral canal. Those ducts, they wind backwards like an inflorescence, and that's called racemose pattern of inflorescence of these ducts. They wind behind, and as I told you before, that 75% of these ducts glands, they reach and settle down into the posterior peripheral part of the gland, and all these will be endodermal because they are the evaginations from the portion of the prostatic urethra derived from the lower and the vesicourethral canal. So these are the large glands. Then from the posterior wall of the prostatic urethra, which was mesodermal, there also there are minute evaginations in the form of simple tubular glands, which are smaller ducts and which surround the prostatic urethra closely. So they contribute to less of glandular tissues and they surround the prostate. They form the periurethral zone, also called the median lobe. So here these glands are mesodermal in origin, and this is the area which is more prone for benign prostatic hyperplasia. That's mesodermal in origin. And the portion of the prostate which is in the periphery, which is being formed by the larger glands derived from the endodermal portion, that portion is more common for carcinoma prostate. Okay? Then describe the age changes in prostate and explain prostatic utricle. So, including prostatic utricle, this question is of 4 marks. So, describing the age changes, you'll have to describe it in the major age group sections, like at birth in a male child, then prepubertal, then pubertal, then the early 20s till 30, and then 40 and 45 age group, and then beyond, right? So this is how I'm going to explain it, the age changes. So remember that at time of birth, this is really small, of course, and in any gland there are two components mainly. One is the parenchyma, which is made up of the glandular tissue, and the rest of the supportive tissue is called the stroma, right? So in a male child at birth, there is mainly stroma and very less of the glandular tissue, and the glandular tissue is like simple small little ducts. That's how it is. Now by the age of 6 weeks after birth, because there is breastfeeding as well going on, so under the influence of the maternal hormones, this epithelium of the simple tubular glands, it undergoes hyperplasia and squamous metaplasia. So that causes for the epithelialization of these glands, and that's how it continues till the prepubertal age group. Now, in the prepubertal age group, that's from 9 years onwards, the gland gradually starts increasing and the glandular tissue starts proliferating. Those simple tubular ducts will now proliferate and ramify, but there is a slow increase in the size. Now, what happens is at the age of puberty, 12, 13, 14 years of life, because of the outburst of the male hormones at puberty, now there is a rapid change in the size and the glandular tissue. You can imagine that the size becomes double the size. At puberty, the size of the prostate becomes double the size which was at its prepubertal age. In 1 year, it gets doubled. Furthermore, the glandular tissue, those simple branched tubular glands, now will start forming the buds, means the acini at the termices of these glandular tubular tissues. So they will form acini. Now from 20 to 30, this gland becomes fully functional, and there is more of ramification of the glandular tissue. The stroma becomes very less in size. More of the gland is filled with the glandular tissue. And furthermore, those acini, those buds at the ends of these tubular glands, those buds will get infolded, right? So infolding of those acini or those buds will cause it to become irregular in shape, those acini, but at the same time it will increase the surface area of the glandular tissues. Remember that prostatic secretions is a must for the ejaculate of the semen. It gives a bulk to the semen as well as nutrition. Fructose also helps to maintain the pH of the semen. Now, beyond 30 till the age of around 45, the gland, although stays at its same size, there is no shrinking in the size, but there is some involutory changes. Involution happens that those infolding of the acini will now be straightened out. Means the irregular acini, which was increasing the surface area by infoldings, will now straighten to form smooth acini, right? So there is the surface area of those glandular elements is now decreasing now, and amyloid bodies increase in number. Now beyond 50, gradually, as you know, the gland itself involutes, and now the reverse will happen, that the glandular tissue will gradually reduce in size and stroma increases in size. Such changes beyond 50 years of life is called senile atrophy of the prostate, and it can also lead to benign hyperplasia of the prostate, or it might lead to carcinoma of the prostate. So those are the age related changes in the prostate, and then you'll have to explain the prostatic utricle. This is actually a male uterus or the male vagina, people say it. So that means it's a remnant of the conjoined paramesonephric duct called the Mullerian duct. So in females, you know that the two Mullerian ducts, the paramesonephric ducts, they come and align in midline and they join to form the uterus and the upper one third of the vagina. However, the cranial portion which do not fuse, they form the fallopian tubes. So in males, actually, this paramesonephric duct, the conjoined portion, it joins the prostatic urethra posteriorly at an elevation that's called prostatic crest. So only a part of it stays there in a rudimentary form within the prostate, and that caudal remnant of the mesonephric duct in males is called the prostatic utricle, which is homologous to the female uterus and the upper portion of vagina in males. And the cranial portion of paramesonephric duct persists in males in a rudimentary form, and that is called epididymis of the testis or hydatid of Morgagni. By the way, let me ask you, what is homologous to prostate in females? So you should remember that in females, instead of prostate, you have is paraurethral glands of skin, right? So we are done with this question. Next, question number 2, short notes question. First one here is, which muscle is known as peripheral heart? You all must be knowing that it is soleus in the back of leg. Although there is another muscle that's called the peripheral heart, and that is lateral pterygoid, because both these muscles have venous plexus within and surrounding them. Soleus actually has venous sinusoids present within it. Those are like the communicating channels between the direct and indirect perforator veins. Similarly, there is a venous plexus surrounding to the lateral pterygoid called the pterygoid plexus of veins. But here you are going to write about soleus because that's more common, more popular, more oftenly taught, and also because there's a reason for it being more important, because it has to pump the venous blood against gravity, while lateral pterygoid pushes the blood when there is sluggish flow in the dural venous sinuses and there is hypercarboxia, or you can say accumulation of CO2 because of the sluggish flow of blood from the dural venous sinuses. And you know, this muscle, lateral pterygoid, is one of the muscle of mastication which opens up the jaw or depresses the jaw and thereby helping to hyperventilate. That's called yawning. So that's the reason when this lateral pterygoid gets compressed, it pushes the venous blood down towards this venous circulation, reaching down to the superior vena cava through the jugular venous system. Remember, this is just for your interest. I have told you maybe sometime they might be MCQ regarding this, or they might ask separately. Right now, you should focus upon the soleus. Mention its origin, insertion, nerve supply, and action. All the four headings are important for every muscle, which are important for your exam. So, origin of soleus, is from the soleal line present on the back of tibia, as well as from the back of head of fibula. This muscle is lying deep to the gastrocnemius as well as plantaris. Out of these three, gastrocnemius and soleus have a combined insertion. Both of these two muscles join to form a common tendon, and that is called tendoachelis or tendocalcaneus, that is inserted onto the posterior surface of the calcaneum laterally. Remember that the two heads of gastrocnemius along with soleus is called triceps surae. And remember, plantaris was in between these two muscles and it was arising from above to the origin of the lateral head of gastrocnemius from above the lateral supracondylar ridge of femur. So remember one thing, that popliteus has an oblique course in the back of leg. So that means it's going to insert medially onto the calcaneum. Not medially exactly, it's onto the medial tubercle of the posterior aspect of the calcaneum, adjacent to the tendocalcaneus. Nerve supply, as you know, all the muscles of the back of leg, they are innervated by tibial nerve. So it's easy. You can simply write the nerve supply is by tibial nerve. And the action, because this muscle does not crosses the knee joint, unlike gastrocnemius. So it will have no action on the knee joint. It takes origin from the bones of the legs. So it crosses the ankle joint from behind. So what it will do is will cause plantar flexion at the ankle joint. That means when you're standing, it helps to elevate your body against gravity and helps you or maintains you to stand on your toes. So soleus helps to stand up on your toes. In that sense, it also is an anti-gravity muscle. Furthermore, let me tell you, while running, this muscle acts as the first gear which initiates your power of running. But as you speeden up your race, gear number 2, 3, 4, they are being taken up by gastrocnemius. So, soleus initiates the run, but your further speed is taken over by gastrocnemius. And plantaris is nearly a vestigial muscle which is not of much use now. And it is said that plantar aponeurosis is the detached portion of plantaris. And don't forget to mention that why is it called soleus? Because it represents the shape of the sole of slippers. Talking about perineal body, this is a fibromuscular nodule present as an anchor in the perineum, in the center, in between the urogenital openings anteriorly and the anal opening behind. Or you can say it is just immediate anterior to the anal orifice, around hardly 2 centimeters in front of the anal orifice. So 10 muscles are attached here, means inserted here. From above, it is the levator ani, the pelvic diaphragm from both the sides. There are 4 paired muscles and 2 unpaired muscles. Among the 4 paired muscles, there is levator ani from above, that's the pelvic diaphragm. Then anterior, it's bulbospongiosus. Then transversely, it's superficial and deep transverse perineal. These muscles pull the perineal body on either side, maintaining its midline position. And posteriorly, its fibers are merged with the unpaired muscle, that is the external anal sphincter, the superficial fibers of this anal sphincter. And also there is a longitudinal muscle coat, that's a longitudinal muscle layer of the anal canal. So it can be an MCQ for you, that out of the different muscles attached to the perineal body, which is a smooth muscle. So answer should be that the longitudinal muscle cord of the anal canal. One more thing to add up here, that in females there's an additional muscle, and that is sphincter urethrovaginalis, the fibers of which also are merged with perineal body anteriorly. Remember, all the muscles attached here, they are all innervated by pudendal nerve. So the purpose of perineal body is to strengthen the pelvic diaphragm and to support the pelvic viscera, the urinary bladder, uterus, vagina, and the rectum and anal canal. But it's more important in females because you have an additional structure between the bladder and rectum, and that is the uterus. So it also has to hold up the weight of the uterus, especially it becomes more important during pregnancy because it's of 5 marks. You can add up few clinical points that due to injury, iatrogenic injury means instrumentation by the surgeon or an obstetrician. If this perineal body is injured, maybe the transverse perineal or puborectalis or sphincter uretrovaginalis. So this will lead to chances of vaginal and uterine prolapse or the rectal prolapse. Generally, during the minor surgery that's called episiotomy to deliver a big size baby or a complicated labor, a minor incision is given there in the posterior wall of the vagina. Generally, it's a J shaped incision given downwards and laterally so as to avoid the stretching of this tear. But due to the muscle fibers getting injured post operatively, there is an exercise to gradually build up the tonicity of these muscles and to strengthen the pelvic diaphragm, and that's called Kegel's maneuver. In Kegel's maneuver, the subject is asked to urinate intermittently, means releasing and holding the urine for every 5 seconds. It's not necessary to practice this while urination, but one can do it simply while lying on bed doing the same maneuver. So it can be done without even going for micturition. But its frequent practice can strengthen the weakened or the torn and sutured muscles. Now, talking about development of kidney. Kidney, is mesodermal in origin. It develops from two components, that's mesonephric duct as well as metanephros. So let me tell you that there is this intermediate mesoderm covered by the parietal peritoneum on the two sides of the paraaxial mesoderm, and this extension, the longitudinal extension of the intermediate mesoderm covered by peritoneum is called nephrogenic cord because both the excretory as well as the part of the genital system also develops from this nephrogenic cord. This nephrogenic cord is divided into four components medial to lateral. Medially, the lining epithelium develops into the genital ridge. Then lateral to that is the mesonephros. While I'm talking is about the lumbar spine and the lower thoracic spine. At the same level, in a transverse section, you will find medially it is the genital ridge. Then you have is the mesonephros. Lateral to that is mesonephric duct, and even lateral to that is paramesonephric duct. This is continued above as well as downwards. This mesonephros, when continued above, it's called pronephros, and when it continues down, it's called metanephros. So these mesonephric tubules also form the human kidney in an embryo during the early weeks of pregnancy, and this is what is called as ontogeny repeats phylogeny because similar kidneys are also formed in sharks and fishes in aquatic life. Later on during embryogenesis, kidneys form from mesonephros. Now such kidney is a functional kidney in an amniotes. And finally, in the later stages of embryogenesis, kidney develops from the lower portion of this nephrogenic cord, and that's called metanephros. So the adult definitive human kidney is being derived from metanephros. And the previous kidneys, which were being from pronephros, then mesonephros, that's an example of ontogeny repeats phylogeny. So these tubules from the metanephros, they form metanephric vesicles, which gradually become tubular, then they start coiling, forming a sigmoid curve, just like a nephron, and its upper end become discoid to form the Bowman's capsule. So remember, the nephron develops from metanephros, while at the lower portion of this mesonephric ducts, which descend down to join at the lower end of this vesico-urethral canal, that's the upper portion of primitive urogenital sinus, where actually future prostatic urethra has to develop, which I told you earlier while I was explaining about the development of prostatic urethra. There I explained you that the mesonephric ducts descend down to join on the back of this prostatic urethra. But before that, this mesonephric duct gives out ureteric buds. These ureteric buds, they ascend and reach towards the hilum of the developing kidneys, and there they form these renal pelvis, major calyces, minor calyces, collecting ducts, and the collecting tubules. So this entire collecting apparatus of the kidney is being formed by the mesonephric ducts. However, the nephrons means the Bowman's capsule, the PCT, the loop of Henle, DCT. All this is being formed by the metanephric vesicles, and the rest of the connective tissue surrounding is formed by the condensation of the surrounding mesenchyme. That's how a kidney develops. Because they have asked about the development of kidneys, so you should also mention about the developmental anomalies. The lobulated kidney, polycystic kidneys, horseshoe-shaped kidneys, unilateral kidney, pancake kidneys. Remember that many viscera descend down during the embryogenesis, just like heart, thyroid, testes, ovaries. But kidneys actually ascend up, because I told you that the metanephros is at the level of the sacral spine, but the adult kidneys are found opposite to the lumbar spine. So kidneys ascend up, but if there is a horseshoe-shaped kidney, this will not ascend up. This will fail to ascend because its two poles, the lower poles are jointed. And while it will ascend, there will be inferior mesenteric artery in between. That's an unpaired visceral branch arising ventrally from the abdominal aorta. So this horseshoe-shaped kidney stays there in the pelvis, even in adult life. So all this you can describe here. Then the third question here is write short answer questions. One is enumerate the muscles supplied by common peroneal nerve. These are 2 marks questions, so you need not write everything you know, just write the limited required information. Not I'm telling you, it's just for your revision. So remember that common peroneal nerve is a part of sciatic nerve. So while it's a component of sciatic nerve, in the back of thigh, it supplies only one muscle, and that is the short head of biceps femoris. Then winding laterally along the supralateral border of the popliteal fossa. After winding laterally along the neck of fibula, under the cover of this muscle peroneus longus, here it gives its last branch called recurrent genicular nerve, which winds medially and ascends to supply the knee joint, and in its course it also supplies a muscle by giving a twig to tibialis anterior. Then within the substance of this muscle peroneus longus, it splits into its 2 terminal branches, the superficial and deep peroneal nerve. The superficial peroneal nerve is the nerve of the lateral compartment of the leg. Here it supplies peroneus longus on its deeper surface, and then it supplies peroneus brevis on its superficial surface. After that, it perforates the deep fascia and it becomes cutaneous. It supplies the anterolateral portion of the lower 1/3 of the leg, that the skin there, and it also supplies the skin of the dorsum of foot, including the medial side of the greater toe, except the first interdigital cleft. Then talking about the deep peroneal nerve, this deep peroneal nerve winds medially after perforating the anterior intermuscular septum and passing through the substance of this muscle extensor digitorum longus. It comes to lie in the front of the leg. Here it is accompanied by anterior tibial artery. Now in its course in the front of leg, it supplies the 4 muscles of the front of leg, and these are tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius. So it supplies these 4 muscles. Then after passing below the 2 slips of the extensor retinaculum, the upper one is a transverse band and the lower one is in the form of Y. So it passes through the stem of the Y, and then on reaching the dorsum of foot, it splits into its 2 terminal branches. The lateral terminal branch of the deep peroneal nerve passes deep to the intrinsic muscles of the dorsum of foot, and these are extensor hallucis brevis and extensor digitorum brevis. So this nerve supplies these 2 muscles on their deeper surface. And remember, the lateral terminal branch of the deep peroneal nerve also has a pseudoganglion, while the medial terminal branch of the deep peroneal nerve on the dorsum of foot perforates the deep fascia to become cutaneous, and it supplies the skin on the first interdigital cleft. Sometimes it's also said that it supplies the skin overlying in between the first 2 metatarsals. So that was just for your revision because it's a 2 marks question. What you should write is actually whatever has been asked. So simply you can make a table and write down the name of these 9 muscles. 1 in the back of thigh, 2 on the lateral side of the leg, 4 on the front of leg, and 2 muscles on the dorsum of foot. So that makes it 9 muscles. So you simply draw a table, enumerate all these 9 muscles, and in front of them write down the name of the nerve supply. That's it. Next question is describe thoracophagus. So thoracophagus, is a type of conjoint twins which have their thorax united ventrally with a common thorax, communicating thorax, right? But because it's a 2 marks question, I believe at your level you need not describe thoracophagus that much, because the intention here is that you have to describe that what type of twins are these. Conjoined twins are actually monozygotic twins. These monozygotic twins, are formed by the fertilization of one ovum by one sperm. That's why they are called monozygotic. And that's why they have the same sex. And not only sex, they are genetically identical completely. So by the end of the first week after fertilization, that inner cell mass actually in that blastocyst stage, that splits into two primordia, means two separate cell masses. Later division of these primordial cell masses to separate cell masses, which were initially the same cell mass, now separately they're going to form two different embryos and will develop into two identical twins. Now this is what's happening is called normal identical twins. So they will share a common amniotic sac as well as common chorionic sac. But if during the separation of that inner cell mass into two separate groups, if this separation doesn't happen completely, so the two cell masses are joined and they start forming two separate embryos. So what will happen? The two fetuses will stay conjoined at certain point, and accordingly they are given different names. So if these identical twins, the conjoined twins, if they are fused or joined anteriorly, means ventrally at the level of thorax, then it's called thoracophagous twins. Similarly, if they are attached with their abdomen, then it's called omphalophagus. Or they share a common head, then it's called cephalophagus. If they are attached laterally, then it's called paraphagus. Sharing a common cranial cavity, then it's called craniophagous. But if sharing cranium along with the upper half of the body, that's like thorax also, then it's called cephalophagus. If they share thorax and abdomen both, then it's called thoraco-omphalophagus, right? So if they are attached with their back now, dorsally, the two fetuses facing opposite, they are joined at their back, and such twins are called rachifagus. And if they are joined dorsally with their buttocks, means at the level of the sacrum, which is called the tail, the human tail, sacrum and coccyx, then such twins are called pygophagus. Pygo means tail, piggy tail, pygophagus. So it's just a name to describe thoracophagus, otherwise you actually have to describe about the conjoined twins. And in case of thoracophagus, they will of course share the common heart, which is a very common thing here. Of course, they will share the thoracic cage as well, with a missing sternum maybe in between. And they may also share other visceral organs as well. And these conjoined twins, they're also called Siamese twins, because in early 18th century, when these nomenclatures were not well derived, so there were two brothers born in Siam. Siam actually is a previous name of Thailand. So from there, this word is derived, Siamese twins. Then the next question here is explain placental barrier. This also is of 2 marks. So one thing you can write that placental barrier is not a very appropriate word. First of all, it actually is placental membrane, because barrier is something which is occluding. Here it's a membrane which allows passage of certain minerals, molecules like glucose and all. So it's not a true barrier. It actually is a placental membrane. Then these are finger-like projections called chorionic villi. And there are three gradings, from the course of embryonic development, placenta also keeps maturing. Initially, there are primary chorionic villi, which are finger-like projections of cytotrophoblasts covered by a layer of syncytiotrophoblasts. Later on, this inner layer, the solid layer, remember that the primary chorionic villi are solid structures. Then the inner cytotrophoblastic layer gets infiltrated by the mesoderm, the extramoronic mesoderm. So then they are called a three-layered structure, and that's called a secondary chorionic. Remember, the primary chorionic villi is made up of two layers. From outside to inside, if you see, outside it's syncytiotrophoblastic and inside it is cytotrophoblastic. Two-layered villi are the primary chorionic villi. Now, when the extramoronic mesoderm invaginates within the cytotrophoblast, then it becomes a three-layered structure and it's called secondary chorionic villi. Later on, this extramoronic mesoderm, this also gets impregnated by the fetal blood vessels, and those are called the villus capillaries, which are actually endothelium resting on the basement membrane. So this tertiary chorionic villi is a four-layered structure. From outside to inside, you have syncytiotrophoblasts, cytotrophoblasts, then the mesoderm, and within that is the fetal capillaries. These villi are actually bathing outside into the pool of maternal blood. The next question is ligaments of knee joint. There are 13 ligaments surrounding the knee joint. So let me help you revise. First of all, you should mention about the fibrous capsule. That is one ligament. But there are modifications of this fibrous capsule in the form of coronary ligament and the short lateral ligament. Coronary ligament is the lower portion of the capsule from its attachment to tibia up till the lateral border or the peripheral border of the meniscus. And the short lateral collateral ligament is the thickening of this capsule from the lateral epicondyle of femur up till the styloid process, the apex of fibula. Then there is ligamentum patelli, tibial collateral, also called as medial collateral ligament, which you know is the degenerated portion of adductor magnus muscle. Then fibular collateral or the lateral collateral ligament, this you know is a degenerated portion of peroneus longus muscle. Then there is oblique popliteal ligament. This oblique popliteal ligament is aponeurotic expansion of the tendon of semimembranosus muscle over to the posterior aspect of the knee joint capsule, strengthening it from behind. Then there is arcuate popliteal ligament. Now this arcuate popliteal ligament is an extension from the short lateral collateral ligament arching over to the tendon of popliteus, making an arch, thickening the gap in the capsule present behind for the passage of tendon of popliteus. So it thickens the margins so that it doesn't get easily torn because of the friction with the tendon of popliteus. Then you have the anterior and posterior cruciate ligaments, ACL and PCL. Out of these two, remember that PCL winds medially and ACL winds laterally. And both these ligaments are intracapsular but extrasynovial. And they are also remnants of, like, let me tell you that PCL is a remnant of lateral collateral ligament of medial tibiofemoral joint, and ACL is a remnant of medial collateral ligament of lateral tibiofemoral joint, because you know that knee joint is a bicondylar joint. I'm telling you all the important points of these ligaments so that this might help you in your future MCQs. Then you have medial and lateral menisci. These are actually made up of fibrocartilage. The medial is more of C-shaped or more of semicircular, and it is the weight-bearing meniscus, and it is also a fixed meniscus. So this medial meniscus is more prone for injury. Also, due to ischemic changes, there are chances of bucket handle injury of this meniscus. because it gets perfusion from the peripheral and central portion. So the middle portion of this meniscus generally in old age undergoes ischemic degenerative changes, while the lateral meniscus is smaller, is more circular, and is a mobile meniscus. The reason is that its peripheral margin is attached with the tendon of popliteus, because you know that popliteus is an unlocking muscle of the knee joint. So when popliteus contracts, this lateral meniscus also moves along with the contraction of popliteus, while the medial meniscus peripheral margin is attached to the deeper portion of the medial collateral ligament. So, medial meniscus is a fixed meniscus, and every time when you plan to sit, femur actually rotates laterally, means the medial condyle is brought out anteriorly out of the medial meniscus. That's called unlocking. So that's why medial meniscus is more prone for wear and tear injuries. Similarly, in case if they ask for ACL and PCL, remember ACL is more common for injury because ACL is shorter and thinner, PCL is longer and thicker, and ACL prevents hyperextension. So because in regular life you are more often extending the knee compared to the forceful flexion. That's why ACL becomes more common. And when there is ACL injured, this is confirmed by positive anterior drawer test. Now there are two modifications of the lateral meniscus as well. These are called the meniscofemoral ligaments. One is anterior meniscofemoral ligament, the other is posterior meniscofemoral ligament. Anterior meniscofemoral ligament is called ligament of Humphrey, and the posterior meniscofemoral ligament is called ligament of Risberg. H comes before W. So remember, anterior is Humphrey, posterior is Risberg. W, I guess, here is silent. The spelling is Wrisberg. And last of all, there is intra-articular, another ligament that is holding the two menisci in place anteriorly, and that is called transverse ligament. You have to write only the names, not what all I have described just now. This is just to help you to solve other questions in future. Next question is descent of testis. Can you imagine how many questions on embryology they have asked? In this question paper, 2 marks here, 2 marks here, 2 marks here, 5 marks here, 2 marks here, and 4 marks here. Prostate, prostatic urethra, prostatic utricle, kidney, thoracophagus, placental barrier, descent of testis. So that makes total of 17 marks. So you can imagine how much important embryology is. 17 out of 50 marks is embryology in this question paper. Now talking about the descent of testes, remember that the testes or the ovaries, they develop in relation to the mesonephros. I've already taught you somewhere above about the mesonephros, that it is the middle portion of the nephrogenic cord. The upper portion was called pronephros in the cervical and the upper thoracic segments. Then adjacent to the lower thoracic and upper lumbar segments, it's called mesonephros. And lower lumbar and sacral segments adjacent to that, this intermediate mesoderm is called metanephros. We're talking here is about the mesonephros. At the vertebral level, you can say is T10, 11 and 12. So after being developed, now testes start descending down to its definitive position. That's about the second month of life. Testes start descending down and they reach the iliac fossa of their respective sides by third month of life. And from 4 to 6 months now, they will stay here in the iliac fossa behind the deep inguinal ring. Then in the 7th month of intrauterine life, this testes traverse the inguinal canal. Very important point. At the 7th month of intrauterine life, testes traverse the inguinal canal and they reach the superficial inguinal ring by the 8th month of intrauterine life. And they reach to the bottom of the scrotum where it is attached by the gubernaculum, and throughout its way gubernaculum has been a torch bearer for the passage of the descent of testis. So the pros and cons of the descent of testis you need not mention here because it's a question of only 2 marks. Now the fourth question, which is about the multiple choice questions. There are 10 MCQs. The first one here is tail of pancreas is a content of gastrosplenic ligament, linorenal ligament, greater omentum, gastrophrenic ligament. So remember that pancreas is a retroperitoneal structure and spleen is connected to the parietal peritoneum with the help of linorenal ligament, which is in front of the left kidney. So pancreas and its vessels being retroperitoneal, remember that the tail of pancreas reaches to the hilum of the spleen through the linorenal ligament. Answer here is B. And let me tell you the other structures found here in the linorenal ligament. One is the splenic artery and the splenic vein. Of course, these structures also are running in relation to the tail of pancreas. And you will also find the linorenal lymph nodes, also called pancreatico-splenic group of lymph nodes. And of course, the lymphatics also. While in gastrosplenic ligament, there are short gastric arteries and the left gastroepiploic artery running there. And gastrosplenic lymph nodes will also be found there. Number 2 MCQ, number of vascular segments of kidney is 2, 3, 4, 5. So remember the vascular segments of kidney is 5. Answer is D. Look here now. If you see a kidney in the sagittal view, it has an apical segment and a lower segment. And the middle portion of this kidney is divided like this. This is the upper pole of the kidney. This is the lower pole of the kidney. And this is anterior and this is posterior. So you have is an apical, lower, then the anterior portion is still divided into two by upper segment, middle segment, and you have is a bigger segment called the posterior segment. So if you see the kidney from behind, you will find it like this. This is the left kidney seen from behind. This is the apical segment, the lower segment, the upper segment, the middle segment, and the posterior segment. That's why remember splenic artery splits into 5 segmental branches in the renal sinus before entering into the renal column of Burton. Number 3 MCQ is commonly sesamoid bone is found with great toe, second toe, third toe, fourth toe. Answer here is A, great toe. Because great toe is not only the two phalanges but also the head of first metatarsal. And below to the head of metatarsal, there is a groove being formed by the passage of this tendon of flexor hallucis longus. So to prevent the pressure over to this long tendon of flexor hallucis longus, below to the head of first metatarsal, there are sesamoid bones on either side of this tendon. Now, this tendon is embraced by a superficially placed muscle of the third layer of sole, and that is called flexor hallucis brevis, which embraces the tendon of flexor hallucis longus. And this flexor hallucis longus, is a muscle of the second layer of sole. So the two slips of this muscle, flexor hallucis brevis, gets inserted onto the proximal phalanx, while the flexor hallucis longus gets inserted onto the terminal phalanx on the plantar aspect. Just like what was happening on the palmar aspect of the digits in palm, that flexor digitorum longus was being embraced by the splitted tendon of flexor digitorum superficialis, which was being inserted on either side of the middle phalanx, and flexor digitorum profundus was inserted onto the base of the palmar aspect of the terminal phalanx. Same is happening here. So the two sesamoid bones, small little bones, are found in the tendon of flexor hallucis brevis, below to the ball of the greater toe. MCQ number 4, long axis of spleen corresponds to the following rib: 9, 8, 10, 11. So the spleen is placed in the left loin region, above, behind and towards the left of the fundus of the stomach. So the outer surface of the spleen is related to the 9th, 10th and 11th ribs. So the long axis of the spleen corresponds to the 10th rib. But let me tell you that according to the Gray's 42nd edition, they say that the long axis of the spleen is related to the 11th rib. Means spleen is placed a little lower down in position. This is the newer concept according to Gray's Anatomy 42nd edition. So those professors, those faculty who might be checking your question papers, and if they are updated with this, and those students who might have marked 11 as the correct option, they might also get it correct. So I'm making 2 plus sign for this, that this is a better option, and this also is not wrong. The 11th rib also you can mark, but it depends, the faculty who is checking this is also updated. Well, it's a risky advice. I would not suggest you to mark 11 as the correct answer, because what's given in your books is more important for you to write at your UG level. So answer will remain 10 here for you people, but for your future, maybe in your NEET PG sometime, if you don't have the 10th option, then you can mark 11th as the correct choice. Fifth MCQ, femoral ring is bounded medially by inguinal ligament, pectineus and its fascia, lacunar ligament, femoral vein. So femoral ring, is the upper margin of the femoral canal, which is the medial most compartment of the femoral sheath. So the femoral ring anteriorly is formed by the continuation of the fascia transversalis. Posteriorly, it's formed by the continuation of fascia iliaca. Laterally, it's formed by the septum, which separates this medial and intermediate compartment in the femoral sheath. It's laterally related to the femoral vein, because in the lateralmost compartment, it's femoral artery in the femoral sheath, and the content of femoral canal, is the ligament of Cloquet or Rosenmuller. So lateral to medial you have is femoral artery, then femoral vein, and then the deep inguinal lymph nodes. So laterally you have is a fascial septum, and medially we're talking is about the femoral ring. Medially it is bounded by the lacunar ligament. This is a modification or derivation from the inguinal ligament, which is a horizontal crescentric ligament. And this also has a clinical applied aspect, that sometimes an abnormal obturator artery might be present over it, which is a communicating artery between inferior epigastric and obturator artery, or sometimes between external iliac artery and the obturator artery. So that abnormal obturator artery might be found over to this, and a surgeon has to take caution while cutting this lacunar ligament while releasing or repairing the femoral hernia. This has to be taken care. MCQ number 6, triangle of Koch is a landmark for atrioventricular node, right bundle branch, left bundle branch, sinoatrial node. So first of all, you should know what's triangle of Koch. Triangle of Koch actually is just an anatomical area, because it's triangle, so it's defined to be confined within the 3 boundaries. So this area is present in the superficial paraseptal endocardium of the right atrium. Now its boundaries are like, one boundary is being formed by the coronary sinus orifice itself, and the other one is a tendon of Todaro, and the other side is septal leaflet of the right atrioventricular valve. So remember, the purpose of this triangle of Koch is to locate the atrioventricular node, AV node, which lies within this triangle. MCQ number 7, fibrous pericardium is supplied by vagus nerve, phrenic nerve, recurrent laryngeal nerve, autonomic nerve. So let me tell you that fibrous pericardium along with the parietal layer of the serous pericardium, both are fused together and both are pain sensitive, while the visceral layer of the serous pericardium is forming the epicardium. This fibrous pericardium is innervated by phrenic nerve. So they innervate all the mediastinal structures there. It innervates the fibrous pericardium, the parietal layer of serous pericardium, the parietal pleura covering the mediastinal surface of the lungs, as well as the central tendon of the diaphragm. And after that, the left phrenic nerve terminates by supplying the cupola of the left dome of the diaphragm, while the right phrenic nerve, after supplying the central portion of the diaphragm, it reaches down into the abdomen by passing through the vena cava opening in the central tendon of the diaphragm, and then participates in the celiac plexus, reaching towards the hepatic plexus and also to the cystic plexus. Remember that the right phrenic nerve also supplies gallbladder, means it's an afferent supply for pain from gallbladder, and that's why the pain of cholecystitis is referred to the right shoulder. Similarly, pain because of splenic rupture or enlarged spleen rubbing the diaphragm from below. So the pain arising due to spleen might be referred to the left shoulder. MCQ number 8. First intermetatarsal space is supplied by the nerve. Obturator nerve, saphenous nerve, superficial peroneal nerve, deep peroneal nerve. So because it's a peculiar example of sensory innervation of deep peroneal nerve, so it's important. Answer here is D. And it's the only cutaneous innervation by the deep peroneal nerve. I have a short video for the cutaneous innervation of dorsum of foot. I will attach the link in the description box or in the comment section. You can watch it. MCQ number 9. Oxyntic cells secrete pepsin, mucus, hydrochloric acid, gastrin. So let me tell you that oxyntic cells are also called parietal cells or pear-shaped cells or flask-shaped cells. They're present in the gastric glands, mainly on the body of the stomach and also on the fundus of the stomach. And the purpose of these oxyntic cells is to secrete hydrochloric acid or HCl. And remember, they also secrete the intrinsic factor, which is meant for the absorption of the vitamin B, mainly B12, cobalamin. So, whatever important points I come across in my mind, I keep telling you so that it might help you in future MCQs. Last MCQ, number 10, Hassel's corpuscles are found in. So the Hassel corpuscles are found in the medulla of the thymus. Remember this. So that's all. Good luck.